So we're going to look at some musculoskeletal pathology. So obviously, I hope, that when we're talking about musculoskeletal pathologies, we're looking at the muscular system and we're looking at the skeletal system. So there's a pretty good chance that at least some of what we talk about will have something to do with joints. So it's important we remember a couple of things about the musculoskeletal system generally. And one of those is that muscle tissue is described as being active. And we may not always think of it as active, but the fact that it can contract and change shape makes it active. So it's muscle tissue that's responsible for generating movement. And skeletal tissue, which most of us can appreciate, is kind of rigid. So it serves a pretty good purpose as protection, like a rib cage and a skull does. But it is passive. And the joint shapes are what allow movement to occur. So that's a pretty big distinction. The skeletal system is going to allow movement, and the muscular system generates movement. And we know that what often connects these two tissues to one another across a joint are tendons. And tendons are a type of connective tissue, and ligaments are a type of connective tissue. The definition between the two of them is that tendon attaches muscle to bone, and ligaments attach bone to bone. So that if we drew a typical joint, we might see one bone that's shaped this way, and the other bone is often described as being congruent. In other words, it sort of matches the shape of the bone that's going to form a joint with. And most of our mobile joints in the body are described as being synovial or diarthrodial. And those are the most movable joints in the body. And they typically have a joint capsule that encloses the synovial membrane. In the synovial membrane, I'm drawing it in green here, it connects between the two bones that create this joint space, and we would have connective tissue on the outside of it forming the joint capsule. And then that space between is the synovial space, and it's filled with synovial fluid. And synovial fluid is a lubricant, and it makes for very easy movement between joint surfaces. And then most of us are aware that on a joint this big, it will have some cartilage. Sometimes it's just called articulating cartilage, and it protects the underlying bone tissue. So I'm going to draw the cartilage in this pinky purple color, and it's also known as hyaline cartilage. And it's the hyaline cartilage that provides the border between synovial fluid or synovial tissue and the rest of the bone tissue. So in this joint, synovial tissue lines the joint except where there's this articulating cartilage. So the bone tissue would be still below this cartilage. So the cartilage is a layer that protects the underlying bone. And we'll see in a few more minutes when we start talking about some arthritis, if we lose that protection, we're going to get some breakdown of the bone underneath. So the cartilage is a very smooth surface, and it provides a nice smooth surface for movement, but it also protects the underlying bone. So we have this typical joint with a joint capsule and synovial fluid and articulating cartilage. And then outside of the joint, we have connective tissue that's joining bone to bone. And that was what we already said, defined a ligament. So most of the time, ligaments are described as being extra capsular. They're outside the capsule. Okay, and if we have a muscle that's coming down, and there's a very simple way to find out whether a muscle is going to be able to action at a joint, it's going to have to cross that joint. And if it can cross the joint, so here's our connective tissue that's going to form a tendon, because this is connective tissue that joins a muscle to a bone, and that's the definition of a tendon. So in this example, we have a muscle that crosses the joint. We can see that it's crossing the joint, and if this joint allows the movement to occur, and this muscle crosses that joint, that muscle is probably going to be able to generate movement at that joint. So if we looked at this from a side view, we might see a joint that looks a bit this same joint, but from a lateral view or a sagittal view. And this muscle that we just drew in was really the quadriceps for our purposes here. And it crosses the joint and attaches down here. Now it happens that if it is, what did I just draw in here? What do we call this? In white, what's that called? Am I talking to myself? Is there anybody out there?
Is that the patella?
It is the patella, yes. Very good. Thank you for that. So the patella is a type of sesamoid bone. You probably remember that name, I hope. But a sesamoid bone is a bone that typically forms within a tendon. In this case, it forms within the tendon that's generated from the quadricep muscle and inserts itself down on the tibial tuberosity and crosses in front of the knee joint, the way we've drawn it in here. This would be anterior, this would be posterior. So if this muscle contracts, it's going to pull on the tibia so that it moves in that direction. And that direction we would call what? What is that motion or direction? When the tibia moves anteriorly towards the femur that way. What do we call that movement? Nobody has any idea what we call that movement. How about just try to come up with some terminology that describes movement? Well, it could be adduction or abduction. It could be internal rotation or external rotation. It could be extension or flexion. And which one do you think that one is that we drew the arrow for?
Extension?
Yeah, that's extension at the knee joint. Okay, so that terminology is important. For those of you that are struggling with this, I don't know if you're struggling with it or if you're just not prepared to turn on your microphone and make a guess. But if it's a struggle, then it's important that you get your terminology figured out as far as that goes. So when we look at these tissues, we've got bone tissue. If I hit that one, we're going to go everywhere. So let me just cut it off so that we don't fill up the whole screen. So that white stuff then is our bone tissue. And you might recall, hopefully you recall, that the bone tissue grows and develops throughout our lifetime, and it's typically a balance between the osteoblasts and the osteoclasts. And blasts build bone tissue, and osteoclasts resorb bone tissue. And when they resorb bone tissue, they free up the minerals that gave the hardness to the bone tissue into the circulatory system, so that the circulatory system can carry those minerals to places where those minerals need to be used. So the bone tissue serves as a reservoir for minerals, especially calcium, but including magnesium and phosphates and even some sodium, that sort of thing. So the concept applies to all of them. We think of it typically with calcium. So this is a lifelong balance. And when we're in a repair mode or a growth mode, the blasts will outperform the clasts. If we're in a situation where we need to free up some minerals, the clasts will outperform the blasts. But it's a balancing act. Muscle tissue, like I mentioned, is active. And in order for it to be active, it needs two big things. Anybody remember what we need for contraction to occur? What two big factors are required for muscle contraction to occur? Well, if it's active, what do you know has to be around? Has to be available to be utilized.
Is it ATP?
Sure it is, yeah, ATP. And we need lots of ATP. Not only do we need ATP to generate a contraction for myosin to be able to bind to actin and then ratchet towards the center of that sarcomere, but we need ATP in order to relax in a muscle tissue as well. Because the calcium that circulates, that's so important for contraction to occur, needs to be taken out of the cytoplasm for relaxation to occur, and that's against a concentration gradient, so that's going to require an active pump. So we need ATP to contract and ATP to relax. And then the other one I just mentioned was the mineral calcium. And hopefully some of you at least will remember that calcium was important because it has to bind to troponin. And then troponin changes shape to expose the binding sites for myosin that are on actin. You remember that from the contraction process? At least kind of remember it when you hear it, as opposed to maybe being able to describe it yourself, but at least you've heard of it before, right?
Yes.
Okay, let's at least go with that, right? Okay, so those are some general properties of the muscle tissue and the skeletal tissue that we should just have a handle on for when we go to look at some of these pathologies. So if we start with the skeletal system alone, what we should recognize is some terminology with respect to damage. If we injure or break bones, that's called a fracture. And we can actually use that term fracture for a lot of things. If you break a blood vessel, you'll sometimes see it written in literature as a fractured blood vessel, but it's telling us the same thing. We interrupted the integrity of that particular tissue. But if we injure or tear a ligament, or we injure or tear a tendon, what do we call it? What's an injured or torn ligament called? Okay, so there's a distinction in terms of when you damage a ligament, it's called a sprain. Unless you've completely ruptured it, that's a different story. And if it's a tendon, it's called a strain. Arguably tendon or musculotendinous injuries are called strains. So those are important to distinguish between as well when you're talking about musculoskeletal pathologies of whatever kind. Now, where have we been here? Okay. So if we look at bone tissue, and we look at what happens if we injure them, they're generally referred to as fractures. And we're all pretty aware. I don't know how many people have had a bone fracture in their life. I've had several, and I'm sure some of you have had at least one over your lifetime. But typically, they're very painful. And they typically repair very well. And they repair well because the osteoblasts and the osteoclasts are active throughout our lifetime. They're being replaced with fresh and younger and productive cells all the time. So when we damage the connective tissue, the special connective tissue that's bone tissue, we can replace it with the exact same tissue. If you remember from the beginning of the semester, that's called a regeneration, repair. We're gonna repair with the same tissue. So in theory, we don't lose function because we're repairing with the exact same tissue that the original tissue was made from. So it isn't a replacement; it's a regeneration. And that's also because bone tissue has a really good blood supply. So it has a good blood supply. It has mitogenic cells, so we can make new osteoblasts to make new osteoid to regenerate the lost or damaged tissues. So when we look at fractures, we define fractures simply as an interruption. So if we look at a typical bone, we know that a typical bone is going to have a cortical section, the dense or cortical bone that's on the outside that makes it look like it's solid. And then we have this trabecular bone that gives it sort of a spongy or honeycomb type of appearance on the inside. And usually what we find in the between the trabecular bone is bone marrow. And in some cases, the bone marrow is red bone marrow. And if it's red bone marrow, what does that mean? We have red bone marrow on the ends of our long bones. What does that red bone marrow do for a function?
Does it create red blood cells?
Yeah, not just red blood cells, definitely red blood cells, but all blood types, all blood cells. So red blood cells, white blood cells, platelets, they're all going to be originating in the bone marrow. They don't all mature there, but they definitely will originate there. So red bone marrow has a different function than yellow bone marrow. Yellow bone marrow is basically triglycerides, and it will insulate and it will provide triglycerides for potential ATP. But basically, when we have a fracture is anytime we get an interruption in the integrity of that bone. So if we look at an X-ray and it's a nice smooth line, and then all of a sudden there's a jagged edge, that's what we're talking about when we say we interrupted the continuity of the bone borders or the bone edges. And so we typically describe that interruption. So the definition, let's go back to white here. Definition for a fracture is going to be an interruption in the continuity of the bone for any number of reasons. And then we're going to describe the fracture based on its location and the angle that the fracture may appear as. And again, we'd have to see an X-ray for this to be able to do this effectively. But the description is based on angle and location. So we might call it transverse. Transverse would be going right across. That would be a transverse. We might describe this being spiral. Spiral fractures are kind of cool to look at on an X-ray. But what they do is they kind of work their way up on a rotation. So usually the fracture occurred because one end of the bone was caught and the other end was twisted or torqued, and it creates a spiral type fracture. We can have longitudinal fractures, and we can have oblique fractures. So an oblique fracture will go on an angle. And let's find another color here. A longitudinal fracture would run along the long axis of the bone that we're referring to. So those are just describing the angles. And then when you look at location, you're going to say it's mid-femoral or mid-humeral. You might say it's proximal diaphysis. Remember, the diaphysis was the end of the long bone. So one end, the one that's closest to the midline or closest to the center of the body, would be described as proximal, and the one on the furthest end would be distal. But if it's close to the end, you'd call it diaphysis or diaphyseal. It's in the middle, it's epiphyseal. That sort of thing. You can also describe it by numbers of pieces. So you can have what's called a comminuted. And I'm just going to use FX as an abbreviation for fracture. Okay. Comminuted means it's in multiple pieces. It's kind of mashed. So that would be a major trauma, from either a really significant fall or significant force that's applied to the skeletal system. It might be seen in a car accident, that sort of thing. You can have an impacted fracture. An impacted fracture might happen when somebody jumps off of a roof or a relatively high surface and lands, hard on your legs, and you cause a fracture so that it sort of telescopes. It sort of drops into the segment below it. So you would see, in this case here, you would see a little bit of, this part of the bone would be surrounding the thinner part above it, and it's collapsed on itself a little bit, but it's been impacted. Green stick. Anybody know what a green stick fracture refers to? You might see a green stick fracture in a young person, an infant or a toddler, because not all of their bone has yet become mineralized, so it has a tendency to bend a little bit. Remember, the base that our long bones are made from is cartilage. So the cartilage is going to have a tendency to bend before it actually breaks. And that's what's described as a green stick fracture. If you've ever taken a branch off a tree and tried to snap it in half, a living branch is going to bend before it breaks because of and that's where this term green stick comes from. Stress fractures. Stress fractures are sometimes hard to diagnose. It's really common in the fifth metatarsal, outside bone of your foot, and a stress fracture might show up as a little bit of a line, almost no interruption in the surface of the bone tissue, but it is a separation, a very almost microscopic separation between the two sides of the bone, and that's a stress fracture. Often no displacement, but very painful because the cortical bone has been broken. You can talk about fractures being non-displaced versus displaced. I think that's fairly self-explanatory. If it's called a compound fracture, let me see if I got some more space here. Anybody know what a compound fracture refers to? That's when the bone breaks through the skin, and now we're at big risk for infection, because remember, the inside of the bone, the medullary cavity, the hollow part of the bone, is not designed to be exposed to an external environment, so it doesn't have the same sort of immune protection or cells that are going to be able to defend against exposure to bacteria that might be on the skin or in the environment immediately around the open wound. So we're very concerned in that situation with infection and or an embolism, a fatty embolism forming from interrupting the marrow, that yellow marrow that was made of triglycerides. And what happens if we have a fatty embolism that gets released from a fracture that's serious like this one? What are we concerned about? Anybody? What happens with a fatty embolism? We've talked about this stuff already. This was in the cardiovascular system.
Can it cause like a heart attack or stroke or pulmonary embolism?
Well, the first thing that we're concerned about in this situation is pulmonary embolism, because the pulmonary vessels will be the first ones that get smaller, right, on the way back in veins, progressively larger veins into the chambers of the heart. When they leave the chambers of the heart, the first small vessels are going to hit are the lungs. So we're particularly concerned about a pulmonary embolism based on these types of fractures. So that's a concern with a more serious type fracture, especially one where the marrow is potentially exposed either to the environment outside of the bone tissue, inside the body still, or even more so in this example where we're talking about a compound fracture that breaks the skin and is now exposed to the external environment. So we can have non-displaced or displaced. Obviously, if it's compound fracture, it's just by definition going to be displaced. And it can be a complete fracture or an incomplete fracture. So you can have scenarios where if we looked closer at the cortex of the bone, there might be an interruption in the bone, but it doesn't actually break all the way through. So we've broken through on the outside, but we haven't broken through on the inside. That would be an example of an incomplete fracture. So it's weakened and it's very subjected to forces that might finish the job. But in the short term, at least, it's described as an incomplete fracture. So again, this compound fracture is the one we got a major concern with because that introduces a whole new set of issues, whether it's infections or embolism type exposures that we're concerned about. So we're going to diagnose this based on your history. In other words, if the person tells you that they fell off a cliff or they fell off a roof or they were in a car accident and now they got a particular part of their skeletal system that's really, really sore, you got a pretty good idea that you've got to rule out fractures. The examination, especially if there's any kind of displacement, you're going to be able to palpate. You're going to be able to feel this fracture. And your patient isn't going to like it very much, that's for sure. But your standard for bones are going to be x-rays. X-rays are probably your gold standard for trying to identify fractures. Now, they can sometimes be missed in an x-ray. If the x-ray doesn't show the right angle, or there's other bones, like, for example, ribs are really tough because ribs cross over one another. If you're looking at an anterior rib, you can see the posterior ribs because of the nature of x-rays. They overlap. But CAT scans and MRIs are effective mechanisms of trying to really zero in on a fracture site, especially if your so-called plain x-rays are not very conclusive, not very helpful. But bones generally heal really, really well. So we're going to talk about that healing process. No, not the X-ray. I want to show you that in just a second. So a couple of terms that your NCLEX exams are notorious for coming up with these sort of obscure terminologies. Well, they're technically not obscure, but sometimes they're a bit dated. So we cover them just to make sure that you've at least heard of them at some point or another. So for example, a fracture, a specific type of fracture that happens at the distal end of the radius and sometimes involves the ulna. Okay, but spares the cartilage, spares the joints themselves. Like think about if you fall on an outstretched hand, if you fall forward or backward and you put your hand out to stop you, then the radius is wide at the wrist and it's going to take most of the weight. There's a good chance that if a bone is going to break, it's going to be the radius. And that's got its own sort of name. It's called a Colles or Colles fracture. So it's distal radius. And like I said, most commonly, they're going to come in, they're going to tell you that they fell and they put their hand out to stop them. They run on an icy surface or somebody pushed them and they put their hand out to stop the fall. And you've got this distal radius fracture that's displaced dorsally. In other words, backwards, which makes sense. Think about your outstretched hand. The hand is going to take the force and the wrist is going to be pushed dorsally, backwards a little bit. And it may be on a little bit of an angle or outright displaced, but when that happens, it's got its own name. A guy named Colles was the first guy to describe it and, had seen it several times in his practice. So, like they often did back in those days, is they just named it after themselves. So that's as opposed to another type of fracture that's called Pott's fracture. And in Pott's fracture, that's an avulsion fracture. We can talk about avulsion fractures, but avulsion fractures, they're like this. So if this was the malleolus, right, the bump down at your foot that sticks out right and left, there's a tibial one and a fibular one, but they'll often have ligaments connected to them. So think about your ankle joint and that malleolus. There's a ligament that connects. Actually, this one I want to talk about. I'm going to take this out of here. Let's get rid of this. This ligament that I want to talk about is inferior, and it runs from the malleolus of the ankle to attach to the calcaneus and sometimes the talus of the ankle joint. And if the force, when you roll your ankle, especially when you roll this so that your foot goes medial, okay, then what's going to happen is your ligament is going to want to tear. If the ligament tears, then like we were saying before, you have a sprain or an outright rupture of the ligament. But if the ligament is maintained, sometimes the ligament is maintained, and that's not the problem. But what happens is the bone separates from the force of the ligament pulling on it. So now what you've got is what they call an avulsion fracture. So in the avulsion fracture, the ligament actually pulled a piece of the bone away from the ankle. If we were meeting in the classroom, I have x-rays from my clinic, and I did a lot of sports injury stuff during my time in the clinic. And I have a lot of pictures of different types of avulsion fractures because of athletes who had got their foot stuck in the turf and then wrenched one way or the other and that sort of thing. But So in a Potts fracture, it's called an avulsion because the medial malleolus, the medial part of that tibia, is pulled away from the rest of the bone. There's a ligament on the inside of the foot in that case, just similarly to what we've been drawing here. It is a strong ligament, so it actually pulls the bone away from bone before the ligament itself will so if it's medial malleolus, we're talking about the tibia. So the good news is that bones heal really, really well. And I've got a picture. We'll look at this picture first. So this picture gives us some examples of descriptions. So we had a simple, this could be called a transverse mid diaphysis, so mid shaft. I think I was using diaphysis at the end, so I should have been using epiphysis. So when it's in the center, in the long part of the middle, it's a diaphysis. So this would be a transverse mid diaphyseal fracture. And it's simple because there's no displacement. So here's compound because it broke through the skin. You seeing this okay? You following my little pencil?
Yes.
And in a green stick, a younger individual might show a green stick fracture where there is some interruption, but not an outright fracture. There's more of a little bit of a bend. Comminuted because we have multiple pieces. And there's impacted right there. So those are just some visuals of different types of fractures that we can see. In this picture, let's take a look at it this way. In this picture, over here we have a normal wrist, radius, ulna. There's your carpals, metacarpals. And here, if you follow the radius and you look, you see that sudden change of orientation and a little bit of translucency there. It looks quite different than what you see in this picture. This picture, there's no loss of integrity. Everything's kind of smooth through there. But here we've got this rough, disrupted area. It's hard sometimes if you're not used to looking at x-rays, but this is white density and then lucency. So that's telling you there's some action going on. Where there's density, there's more deposition of bone tissue going on. And in the lucent area, that might have been the original fracture site, and we're remodeling in this picture. This isn't the greatest, but I was just trying to find something to be able to show you. Let's see now. Yeah, there we go. So this picture is going to show us some of the steps involved with repair. I want to pick a color that we can see in both. Maybe orange will do it. So what we're looking at when we look at bone healing, remember during any kind of repair process, we're going to see inflammation. Then we get repair. And then we get remodeling. And bone tissue is no different. Bone tissue has a great blood supply. Remember, that was a characteristic of good repair. Mitotic cells, also a good characteristic, and an intact extracellular matrix. And a bone tissue, the osteoid represents the extracellular matrix. So we have all the ingredients we need for a good repair. So with inflammation, remember, we're going to get vasodilation. We're going to bring white blood cells to the site. We're going to bring repair cells to the site. In general tissue, that's fibroblasts. In bone tissue, it'll be osteoblasts. Because remember, bone tissue was a type of specialized connective tissue. And really what made it special was that the osteoblasts were specialized fibroblasts. So we've got osteoblasts coming to the area with the increased inflammatory signals, vasodilation, permeability, and so on. So our hematoma in the first 24 to 72 hours, we're going to see that hematoma that localizes the blood flow and sort of traps it in that location. And again, like we've talked about right from week 1 this semester, that it's typical of most types of tissue healing. And we're going to see clotting and everything else that's going to have to go on in order to minimize any kind of blood loss. And then step number 2, we've got the formation of what's called a fibrocartilage callus. So it's sometimes called a procallus. By now, you're probably familiar with the terminology. When you see pro or pre in front of something, it's not the final product, right? It's a precursor or something that's not yet activated, like pre-vitamin B. It's also known as a soft callus. So that term, soft callus, is a pretty good indicator that although the goal of this callus is to unite the 2 broken ends and begin the process of repair, this is not a stable callus. So most of us are generally aware that we cast a bone. Most tissues in the body, we try to maintain a bit of mobility during the repair process to minimize scarring and encourage blood flow and so on. Bone tissue is an exception to the rule in the respect that the 2 ends of the bone need to be approximated, get close together, and they need to be immobilized in order to form first the soft callus and then the hard callus. Okay, if this step is interrupted, here, we may form a non-union. And if we form a non-union, that's like saying we've created a new joint. So the granulation tissue will not attract minerals, it won't get hard, and as a result, stays mobile. So it's an unstable. You can imagine if you had a mid-diaphyseal fracture of the femur, and you didn't immobilize it, and you developed a non-union repair, then you're going to have instability in the middle of the femur. So you can pretty much appreciate how that would feel and how effective that's going to be for the longest bone in the body that has the greatest forces being applied to it between the quadriceps and the hamstrings and the gluteal muscles. So that's going to be a problem as far as that goes. So this process, if this was 2 or 3 days, and this is going to be a continuation. So this might be 3 days to maybe 1 to 2 weeks. So that's days, just so we're sure. And then we're going to go from days to weeks. During that phase, the goal is to go to the bony callus. So that's a continuum. And the osteoblasts are going to take over from fibroblasts. Mineralization is going to begin that forms a bridge between the 2 fractured sites. And then we're going to get ossification. So the arrival of the osteoblast doesn't guarantee that we've got bone formation going, but ossification describes that. And ossification is going to be weeks to months. And the remodeling in bone tissue is months and sometimes years to complete the remodeling. But what you can see in this picture, and I'll show you just down below here, if we looked at a bone that has begun the repair process, so here's our 2 non-displaced surfaces of the bone tissue. Okay, and we've got our granulation tissue, so we start with some vascularization, we bring in some fibroblasts, and we create this granulation tissue that forms our soft callus. Then osteoblasts are activated and drawn to the area, and they start the process of laying down new bone, osteoid attracting minerals. We start to take a soft callus and create a hard one, a bony callus. But initially, we overgrow in the area. And, it's easy to imagine why. We're trying to establish the union and establish stability as aggressively as we can. But as a result, you've kind of got this area of bone tissue that's much larger. And if you have a bone like the clavicle or even the tibia or the edge of the ulna, the bones that are close to the surface of the skin, you can feel these calluses when they're healing. You can feel the bump. They're going to be painless at that point, but they're palpable. You can feel them, and they're easy to bump into, and that's not going to be painless. Because this bone tissue does have nerve fibers, pain receptors. So this is the hard callus that we're forming within a few weeks. And that's why you keep a cast on for at least, depending on how old and what location the bone fractures in. But you may keep the younger the person, the shorter the time frame that's required to get to this stage. A young person's bony callus might form within 2 to 3 weeks. So a cast might stay on for 4 weeks. But as you get older, about every decade you are older, it requires another 1 to 2 weeks of casting, because the process is just going to be slower as far as that goes. But our goal, if this is what it looks like after a few weeks, maybe even 6 or 8 weeks, what we want is, maybe at 3 months, we can still see that there's a little bit of a dense area here, but it's much more smoothed out. And a year later, it may be very difficult at all to be able to see that there was ever a fracture. Sometimes, if you know there was a fracture site, you might see just a really simple, dense line that represents the union of the two broken bones a year or so later. But even that's hard to find, and particularly if you don't know the history, to look at that area, you wouldn't notice it necessarily. So this bony callus forms, that's the time when a cast can come off, and because that's representing stability. But the soft callus does not represent stability. So yeah, you can remodel for months, maybe up to a year or two, and not require casting for that length of time, as long as the bony callus formed and the stability was established. So that's our repair process when we're looking at bone tissue. Now, what sort of things would we describe as complications? So remember, we've got complications, we've got sequelae and complications. We've got scenarios where we may create a new problem if we aren't as diligent or as accurate as we should be in the repair process. But we could have delayed healing. So we want this process to start in the first 24 hours. But delayed healing could be for nutritional reasons. What sort of things do you think might be important for a good repair of bone tissue from a nutritional point of view?
Eating lots of calcium.
Sure, calcium would be a big one. So we might be thinking in terms of calcium, definitely protein. Vitamin C in particular is really good for promoting bone metabolism and bone healing. So those sorts of things are important nutritional factors. Delayed healing could be if we went to early, for example, early weight bearing without a cast, because that might promote our non-union that we're talking about. If the cast is too tight, you could choke off blood flow to that area and create a gangrene type problem. There's those sorts of problems. That's sometimes in the case of a cast that was too tight, or even if the inflammation that occurred was in an area where the inflammation could be trapped. Sometimes you might have heard of a compartment syndrome. So that may cause enough pressure to create what's called avascular necrosis. Avascular necrosis is going to be decreased blood flow to the fracture site, leads to ischemia, and we all know what happens when we get to ischemia. Not enough oxygen and a signal for necrosis to occur. If we have an open type fracture, we mentioned that we're concerned about infection. A bone infection is called osteomyelitis. The myelo part is referring to the bone marrow. So it's the bony marrow that's inflamed because of an infection. So again, that marrow is not usually equipped to fight off bacterial infections because it's enclosed under normal conditions. So we're also concerned about osteomyelitis, the compartment syndrome we talked about or mentioned, and the fat embolus or emboli. that we mentioned earlier as well. We also need to be aware that nerves follow in troughs or tracks in some bone tissue or across joints. So there's always the possibility that during let's call this neurovascular injury. So during the repair process, you can appreciate that if you grow a callus, it may put pressure on an adjacent nerve or an adjacent blood vessel and impede its function. So there's always that possibility of neurovascular damage or injury, either from direct trauma during the fracture process or from the displacement that's created as the callus forms, or pressure from a cast. Those are all possibilities as far as that goes. Okay. All right. So let's switch gears here and talk a little bit about arthritis. So arthritis generally is any condition where there's inflammation of a joint. Arthro is joint, inflammation is itis. So that name just simply means that there's some joint inflammation going on. And there's over 150 types of arthritis that have been identified. You've heard of some: rheumatoid arthritis, osteoarthritis. There's conditions like gout, juvenile rheumatoid arthritis, arthritis associated with systemic lupus, ankylosing spondylitis. There's psoriatic arthritis, all kinds of different types of arthritis. Many of them are associated with other diseases or conditions, and they're named that way, like the psoriatic arthritis. But basically, millions of Canadians are affected. So this is a very large category. There's probably in the vicinity of 5 million Canadians annually identified with some form of arthritis. And it basically means that the total number of Canadians with arthritis is going to be increasing every year. So this is an incidence. So the first type we want to talk about, which is the most common type, is the one that you can see in this picture here, is called osteoarthritis. And it's abbreviated as OA, and it's also seen as degenerative joint disease. So this is the most common type of arthritis. It's very progressive. So typically it may present initially as kind of mild inflammation, may affect the joint, a few days here and there, but then with increased frequency, it gets more painful, might involve more joints, because typically once one or two joints are involved, nearby joints are going to compensate. And compensation by definition is not normal. So the forces and the mechanics across the compensating joints change, and then eventually they break down. So because that's where the progression comes from. So initially here's the key sort of pathophysiology when you think about osteoarthritis. It's the articular cartilage. So that cartilage that lines or coats the bony surface. That's the stuff in blue in this picture here. We've got a meniscus, so we're looking at a knee joint in particular when you talk about a meniscus. Meniscus is a thick sort of wedge of fibrocartilage. And the hyaline cartilage, the articular cartilage, is more like a coating on the surface. So meniscus is an additional thickness of cartilage that, in the case of the knee joint, helps guide the movements of the knee. But basically what happens in osteoarthritis is that there's articular cartilage injury. It might happen from a sports injury or some sort of repetitive injury to the area. Could be from a surgery, you know, but basically because it's progressive, the presentation may take years before it starts to be symptomatic. So it typically is going to involve weight-bearing joints. So again, we never say never, never say always, but typically weight-bearing joints. So the articular cartilage has an injury, and then there's going to be some loss of integrity from that injury and some remodeling in response to that injury. That's all fine, that's typical, but it creates an imbalance. So I use the abbreviation give rise to or leads to, right? So GRT gives rise to imbalances and those imbalances are going to change the integrity of the joint. So if you grind down one side, the joint space is reduced on one side, it gaps on the other side, and you change the mechanics across that joint. In this picture here, we see this nice picture here, and the lines of force, you know, they're pretty uniform. They go kind of down the center of the joint, and the weight is distributed evenly. But here we've got a reduced joint space here, an increased joint space there. And so we're going to grind on this side. You see this change in shape of the bone. This bone is trying to adapt. And essentially what's going to happen, eventually what happens is the bone literally tries to grow to fuse the joint. So on the side that's grinding down, the reduced joint space, it may start to try to fuse because movement hurts. So the tissue tries to fix the problem of movement by creating fusion. That's another picture with more advanced types of osteoarthritis. So we're talking about this imbalance that forces adjacent joints, so nearby joints, compensate. So that joint isn't working properly anymore. If that's your right knee, that's going to put more force on the left knee. It's going to put more force on the same side hip and or ankle, right? Because those joints are going to have to make up for some of the force that goes through that you're trying to avoid on the knee. You start to limp, it puts more weight on the non-involved side. Sooner or later, the non-involved becomes just as involved. So these joints are trying to compensate for accommodation, and inevitably they fail. So that's where the progression comes from. So this is also known as the wear and tear arthritis. So this is very typical in almost anybody over the age of about 40 is going to have some degree of wear and tear on one or more joints in their body, typically the weight-bearing joints. If you're a heavier person, there's an increased strength. So if you were very athletic, especially someone who's very athletic who had some injuries, then you're more likely to have some wear and tear type arthritis as you get a little bit older. So the cartilage is interrupted, as we've used that term now a few times. But those things, those ridges or those tears in the cartilage are described as fissures. So fissures are where you see the bone showing through the cartilage. So in here, we've got exposure to the underlying bone. As a result of those fissures, the cartilage gets thin and then breaks or wears down completely, so the underlying bone is exposed. So you end up seeing the bone underneath is described as being pitted and with erosions and then growths to try to correct the forces go crossing the joint. So there's the loss of this protection, so the underlying bone now is exposed. It gets sometimes described as being sclerotic. Sclerotic means on an X-ray it shows up as dense white. And you can see the growth here. You can see this extra growth, these little bumps that they're drawing in here. So on an X-ray, this extra bone would show up as sclerotic. It would be denser, whiter. And that's an indication of this extra growth that's going on at the joint surface. And it would not be balanced. I kind of drew that evenly across, but it's not going to be even across, that's for sure. Whoops, that's what happens when I erase there, so we won't do that. So the underlying bone has been exposed. The synovium, so that synovial tissue, is inflamed from the wear and tear and the injuries to both the cartilage and the bone tissue. And it's going to secrete more synovial fluid. So if we get more fluid in the joint space, what's that going to present as?
Edema.
Yeah, but it's not technically edema, because edema we would be describing if it leaked out of blood vessels. So it's a little more of a localized source of swelling, but it's definitely going to be swelling. And it's going to reduce the range of motion, stiffness. And if you think about this joint and you think about what the joint is trying to do, is it's painful every time it moves. So it's trying to naturally immobilize. First with this swelling, filling up the space and reducing movement. Then with this bony overgrowth that's literally going to try to grow into the other bone and stop the movement from occurring. It'll actually try to fuse the joint. So the ligaments thicken. And part of that's because they're being stretched constantly, so they respond to that constant stress, just like the heart did with hypertrophy. But the ligaments are going to thicken, and they lose elasticity. So again, another effect on range of motion at the joint. So our patient here is going to have morning stiffness, because the longer they're immobile, the more swelling fills up the joint space. If it lasts more than 30 minutes every day for several months, then that's part of the diagnosis as far as that goes. We see bony enlargements. The joints themselves start to look bigger. So they're like, you can look at an individual who has osteoarthritis, you can look at the joints of their hands, their proximal and their distal interphalangeal joints, the joints of the fingers themselves. So it's very common in people with osteoarthritis to have that distal interphalangeal joint swell up, and so that becomes very noticeably expanded. And you can look at grandma and grandpa's hands, because inevitably they have a little bit of arthritis, more than likely, and those joints in particular will show up as being swollen. And they're not always painful, but they do show that change in shape. And pain, especially on weight bearing, are the big things to look for in somebody with osteoarthritis. Let's see here. So for a diagnosis, you're going to look for some of those things. You're going to look for this morning stiffness that's chronic in nature and progressive. Progressive might mean that the one joint that's involved is getting progressively more painful and more stiff in the morning, but more likely you're going to see multiple joints. And the joints are often logical. So if it's the right knee that's the problem, then it might be same side, alternate joints, or the opposite side, same joint. So in other words, if I'm talking about the same side, we're talking about the hip and the ankle. In the case of the knee, we're talking about the opposite side, we're talking about the opposite knee. So there's even some statistics that sort of say if you've got, you know, if the most common joint in the body to get osteoarthritis is the knee joint. And, you know, 50% of the time, if the right knee is the first joint to be involved, then the left knee becomes involved over time. But the same side or the opposite side hip is very close to being the next most common joint, because again, the healthy joint or the healthy limb will try to compensate for the unhealthy one. So when we look at, you know, for a diagnosis, a lot of it is clinical in basis. It's the history, trying to figure out the time frame, and it's the location and the description that the patient is going to give you as far as which joints are involved and how long they've been involved. So it's characteristic. The term crepitus is often used, is a fancy word for joint noises. So, you know, when you might occasionally, even at your age, you might get up from a chair, get up from the ground, and you feel your knee crack, right, or your ankle crack. That's what crepitus is. But in someone that has chronic osteoarthritis, their joints are making all kinds of noises all kinds of times, because it's an indicator that the mechanics are not right. And so the roughed joint surfaces are noisy. There isn't as much lubrication, there's more stiffness, there's more force required to get the joints to move, and as a result, they're noisy. And people with osteoarthritis almost never complain of acute pain. It's almost always low-grade chronic. You know, some patients, even when they go off of weight bearing, they still feel joint pain, but they won't ever describe it as being acute. It's not like a brand new injury. But it's chronic, and it can get very depressing for people that are in constant chronic pain. So the most common joints, first of all, any joint that has a history of injury is at risk. Even somebody who you might not think of is athletic per se, might be a knitter, you know, somebody who knits all the time, but that constant repetitive rotation that's occurring at the wrist joint can create an imbalance. And if that imbalance isn't corrected for or you know, accommodated for, then that imbalance creates forces going across the joint that may eventually lead to disrupted cartilage. Underneath the cartilage, the bone starts to change and adjust, the ligaments become involved, and by definition, we're dealing with a type of mechanical osteoarthritis. But like we mentioned, outside of trauma, knee joint is the most common. Then we go to hip joint. Then we go to some of the joints associated with the hand. And then we see foot and ankle. And then we'll see low back. So we're gonna remember some of this when we look at rheumatoid arthritis, because we'll see some very different presentations in rheumatoid arthritis. So in North America, we say there's about a 50% prevalence of developing knee pain of an arthritic nature in your lifetime. But 25% of the population over 85 has some amount of osteoarthritis. Okay, those are not statistics you're ever going to get asked by me, but to give you an idea of how prevalent osteoarthritis is. So it's a very common presentation. If it's going to present in the hands, it's most often the distal interphalangeal joints, DIPs. So if you've got a hand, here's your thumb, and here's your finger. That's your proximal. And that's your distal. That's your DIP. and that's your PIP, proximal. So in someone with osteoarthritis, it's more common that you're going to see that swelling and that increased enlargement in the distal interphalangeal joint. So it's a little more classic in the distal interphalangeal joint. That's supposed to be a thumb. And those nodes that form around the joint, they again have a name. You won't need to remember this, but you can read about it. Heberden's nodes. They're a classic presentation of osteoarthritis in the hand. So this pain of osteoarthritis is typically relieved by rest and by getting off your body weight. So getting your hips and your knees and your ankles up and off the ground rather than be constantly exposed to gravity. So what do we do about treatment? Because it's a gradual onset and a progressive onset, it's really important that we try to maintain range of motion. Mobility exercises, preferably without gravity. So riding a bike is great, swimming is great. Those are range of motion exercises. Later on today, we're going to talk about osteoporosis. And in osteoporosis, we want weight-bearing exercises because the goal is different. The problem is different, so the goal for correction is going to be different. And we're to maintain range of motion and try to normalize the forces and biomechanics on the joints. So sometimes in a gym, it's easy to do that. You can get in on a machine and you've got your foot strapped into place and you're sitting on a seat that aligns your joints and sort of forces good alignment. If you've got disruption and imbalance in a joint and you're running free, you may just make it worse. So that's what we talk about when we say forces and biomechanics, try to normalize those as much as possible. We got lots of modalities that can address the inflammation from very, very basic modalities like ice. Ice therapy is very good. Ice therapy is probably best used on an intermittent basis. In my clinic, I used to do 10 minutes on, 10 minutes off. So I would just tell patients, go 10 on, 10 off, 10 on, 10 off as often as you got 30 or 40 or 50 minutes. And that will address some of the inflammation as far as that goes. There are more involved modalities. In a clinic like mine, I had, some electric currents and some ultrasound and some laser therapies, those sorts of things. Those can all, to varying degrees, address inflammation and address biomechanics at a joint. Manipulations, adjustments, medications like anti-inflammatories can be of some benefit. Aids that try to minimize the pathomechanics, so canes and walkers and bracing can be helpful. Surgeries work. In the case of a very debilitated joint, we know hip surgeries, hip replacements and knee replacements. They even have replacements of other joints. They don't tend to be as successful as hips and knees are, but they're still available to severely disabled people with types of arthritis. So osteoarthritis responds very well to those types of interventions. The joint replacements solve a lot of problems in people with very advanced osteoarthritis. So let's take a look at rheumatoid arthritis. Which one do I have here? Here's our rheumatoid arthritis picture. So in rheumatoid arthritis, the joints that are involved are going to be a bit different. The whole pathomechanics is quite different. So in rheumatoid arthritis, So the thing about rheumatoid arthritis that makes it very different is, number one, it's systemic. So that's an important differential. With osteo, it was degenerative, and it was because a joint got injured at some point or another, or the mechanics on that joint were changed. So it was typically a single joint, at least initially. But the other thing that makes this rheumatoid arthritis unique is that it's also autoimmune. And it's a situation where antibodies are generated against our own tissues, especially synovial tissue. So basically what happens is there's a factor that's been identified in people with rheumatoid arthritis. Not everybody, but the majority of people with rheumatoid arthritis have what's called rheumatoid factor circulating in the body. And what rheumatoid factor is a complex with IgG. So it's a complex that contributes to the joint damage. So these rheumatoid factor IgG complexes target the synovial tissue. And as a result, T cells and B cells and macrophages are activated. B cells are the ones that produce the rheumatoid factor in complex with the IgG, and they become an autoantibody. So that's where the autoimmunity comes from. And so the IgG RF complex creates an aggressive inflammatory response. So this complex targets synovial fluid, and we get this very aggressive inflammatory response. And it's going to be prolonged because the antibodies remain, those complexes remain in the circulation. So you get an accumulation of dense aggregates and immune cells at the site of the inflammation. So we get aggregation of immune cells and infiltration of the synovial tissues. And that's going to create swelling, obviously, with this chronic inflammation that's forming, and new blood vessel formation. So we get edema and what's sometimes called NEO for new vascularization. And that is sort of a positive feedback. That stuff builds on itself. So we're going to get hypertrophy. So synovium and synovial tissue, those are interchangeable terms, right? I'm just trying to condense my writing a little bit. So that's going to hypertrophy and start to encroach on the surrounding cartilage. And it kind of covers the cartilage with this mess, this aggregate and infiltration of these white blood cells in the area. And so it's known as pannus. It approaches on the articulated cartilage. So, and this pannus is filled with enzymes that start to destroy the articulating cartilage. So again, we're going to get some of that bony erosion. We're going to get cysts that form in the bone tissue, and the bones start to split, fissures. but the joints that are affected are going to be a little bit different. So the other thing that happens here is that we get involvement. Let's see if we're going to be able to see this. So it's going to recruit or involve the ligaments, tendons, and joint capsules. So what's going to happen in those tissues is we're going to get some fibrosis, we're going to get ruptures, and we're going to create imbalances. So one of the things about rheumatoid arthritis, when these ligaments and joint and tendons get involved, is you can actually have the rupture of a tendon. So imagine you've got a finger that you can orient straight. When you point your finger straight out, it's nice and straight. But if you lose the flexor, for example, or maybe it's easier to visualize, if you lose the extensor that crosses the top of the finger, then there's no longer a force that can straighten out your finger, and your finger is going to drop down. And you're not going to be able to pull it back up effectively. And if you lose it across one joint but not the other, then your fingers start to deform. You can see in this picture right here, when you look at this finger, you can see you've got flexion at the proximal interphalangeal joint, and you have extension at the distal. So what's happened is this tendon has been broken on the distal joint, so there's nothing on the flexor side to counter the extensor. But the flexor is still at the proximal one. So we get flexion at the proximal joint. Can you see that well enough in this picture? Do you hear what I'm saying and see it in this picture? Flexion at the proximal joint and extension at the distal joint. Anybody there?
Yeah, that
Yes.
Okay, so that's called a swan neck deformity. So if we look at this finger, if we looked at this finger right here, the fourth digit here, if we looked at it in a lateral view, it would show that the proximal interphalangeal joint is flexed and the distal one is extended. So we've got a tendon in here that can keep this joint flexed, but no tendon down at this joint to keep that one flexed. So it looks like it's extended. So it's called a swan neck or just swan neck deformity. Because it gives you that sort of impression of a swan's neck, or it gave somebody that impression, and that's why they called it that. So that's kind of classic of what a rheumatoid hand looks like. Remember what we said with somebody with osteo was that the distal phalangeal joints swell. But in someone with rheumatoid, it's more likely to be the proximal joints. And if we tear tendons and ligaments, we get these deformities as a result. So muscle tissue on one side will atrophy, on the other side it can hypertrophy. You get what are called subluxations, which are partial dislocations. You get contractures. That's what we're showing here. We've got a shortened tendon that's creating flexion at the proximal joint. That's a contracture, and then these deformities. So signs and symptoms in somebody with rheumatoid arthritis are going to be a little bit different, but they definitely overlap with all other forms of arthritis in general. But the classic presentation is that, and what makes it different than osteoarthritis is that very often it's bilateral and symmetric. So if your thumb is involved on the right side, it's more likely that your thumb will be involved on the left side as well. So we see bilateral, symmetric, and multiple joints means we call it polyarthritis. So remember, with osteo, it usually started with a single joint and might recruit additional joints over time, but starts singular. This is bilateral, usually involves, again, usually we'll put in there, smaller, non-weight bearing joints. So that's another way we can differentiate between them. And because of the systemic nature, the presence of antibodies, we also will see some systemic presentation. So the patients that have a flare-up of rheumatoid often generally feel kind of unwell. They're tired. And in rare cases, they may even have some fever associated with it. But it classically shows with exacerbations and remissions. Osteoarthritis is kind of slow, steady, and progressive, but rheumatoid can have flare-ups. That's what the word exacerbation means, is exacerbation means flare-up, and remissions means it's gone away for a little while. But remission is not acute. That's why the word remission is used. It's an indicator. So we know that the distal interphalangeals are typically not involved, so that helps us differential between osteoarthritis. If the spine is involved, it's typically cervical, so that fits with smaller non-weight bearing. And they are the joints that are involved are painful on palpation. So you do a physical exam, they're painful to touch. The big thing is that we try to prevent with early intervention is the joint deviations, especially in classic rheumatoid arthritis. We have what's called an ulnar deviation. This picture kind of shows it a little bit. An ulnar deviation is the deviation that's going to go in towards the ulnar side. Because of an imbalance between the ligaments on the radial side and the ulnar side, you get a pull towards the ulna. So that's called ulnar deviation. Swan neck deformities where you have hyperextension of the distal and flexion at the proximal, and vice versa can give you different types of deformities. Actually, you know what? This deformity right here is not. That's called a boutonniere when it's flexion at the proximal and extension at the distal. That's called a boutonniere's deformity. I apologize for that. IERE, and swan neck is exactly the opposite. So in swan neck deformity, we're gonna have the proximal is even a bit extended, but the distal, that's the swan neck. I knew when I talked about the swan neck that this didn't give us the swan neck. So there's our PIP, it's extended, and our DIP is flexed. That's the swan neck. Again, I'm not going to ask you questions about those sorts of terminologies because they're just, when you start putting people's, or in this case, animals' names in the descriptor, it's just an unnecessary memorization for us at this point. If you become arthritic specialists, you'll spend more time on that sort of thing. So what else should we know about our rheumatoid arthritis? We're still talking about RA, rheumatoid arthritis. The signs and symptoms can develop very, very quickly. So that's a bit different again than osteoarthritis. Or they can be just like osteoarthritis, be very gradual and develop over weeks to months in their presentation. But the big thing is that they're going to be stiff with swelling when immobile. That's not a differential because that's what osteoarthritis does too. But we're going to lead to progressive disability and the reduction in the ability to do daily tasks. Like someone might notice that they can't grip the jar and twist the top off anymore. Or they have trouble with door handles, that twist that's required for a door handle. So you can see in some retirement homes and places like that, they've switched door knobs to levers because it's a lot easier to push down or lift up on a lever than it is to try to twist on a lever. So the disability is progressive, and it may lead to loss of activities of daily living. So the diagnosis it's important we have to differential. The diagnosis, it's important to differentiate and rule out osteo. Well, osteoarthritis is progressive. It's a little less intense overall and a little less aggressive on the joints that are involved than rheumatoid. Rheumatoid can be very aggressive very quickly. So this diagnosis, a blood test and seeing the rheumatoid factor that we talked about, if it's in the blood, then it's suggestive, but not diagnostic. So that's an important differentiation. Suggestive, but not diagnostic. Probably somewhere plus or minus 85% of those with RA are positive for RF, the rheumatoid factor. So basically what you're going to do is you're going to take that positive finding with rheumatoid and you're going to look at the joints that are involved. You're going to follow the progression of the symptoms and also rule out other pathologies. So the treatment's a little bit different because the potential for joint destruction is a little more real, and the etiology for that joint destruction being synovium and synovial inflammation is a little different. Whereas osteoarthritis is mechanical, we have some mechanical solutions. With rheumatoid, it's a little trickier. So it starts with pain management. And those start at the, at the introduction level would be non-steroidal anti-inflammatories, those sorts of things. Various other modalities like ice and heat therapies. For people with long-standing rheumatoid, they get some benefit from wax. It's an old therapy, wax therapy. You dip hands in melted wax, and it's pretty hot in order for the wax to melt like that. But the layers of wax on the hands are soothing, and they often result in at least some temporary increase in range of motion and relief from some of the pain after you peel the wax off, of course. But the other goal here is also the prevent the pathomechanics. So that's bracing to counter deformities, especially in the wrist and hand. So you may wear splints at nighttime to prevent that distortion from occurring. Range of motion exercises, again, with a focus on mechanics, that's important. There's a whole classification of medications that some of you, I don't know where you are in your pharmacology, but there are a classification of medications that are called the disease modifying anti-rheumatic drugs, So these are pretty specific, pretty potent types of medications. They're anti-inflammatories, but they also are described as being immunoregulatory. So they're designed to try to address the immune component to the etiology, attempt to block or inhibit various immune enzyme pathways to reduce some of that synovial inflammation and pus formation. A lot of the most recent research in medication is addressing various immune mechanisms because of the more we recognize this as being an autoimmune type of problem, to try to address the source of the onset of rheumatoid. So the treatment's going to be quite a bit different as far as that goes. Let's take a short break. Does that sound like a good idea?
Yeah, that sounds good, sir.